Um, Hi, everybody. I'm Shannon Shai. Welcome to another edition of Rise Beyond OCD interviews with the icons of the OCD recovery community. As you've seen, this is the dream team of all of the great therapists and advocates in the OCD recovery community, all of whom I've met through my association with the International OCD Foundation. And I'll get to our guests in a moment. I have a few admin remarks that I read every time so we don't forget. Whether you're living with OCD, supporting someone you love, or working in the mental health field, this is a caring space where we can learn, connect, and find hope together. And just a quick reminder, what we share today is meant for education and support, not a substitute for professional care. If you ever find yourself in crisis, please reach out. You can call or text 988 for the Suicide and Crisis Lifeline, or 911 if there is immediate danger. For international support, visit findahelpline.com. You are not alone. Healing and recovery are achievable, and we are here to move forward together. Today's interview is being live streamed. The interview, like all the other interviews in this series, are being recorded or is being recorded for later viewing on my YouTube channel and on my website, ocdrecoveryturningpoints.com. Everyone will be muted, and you can have your video on or off. It's up to you, except mine and our guests, of course. The chat room is open. I ask everyone to be respectful of others and maintain decorum. We have never had a problem with that. I do not expect that we will have that today. And we will have a Q&A at the end with Dr. Storch before my final question. So you can put your questions in the chat and I will try to get to them as time allows. So with that, let me introduce our special guest today. Dr. Eric Storch, PhD, is a professor and Mackingvale Presidential Endowed Chair in the Department of Psychiatry and Behavioral Sciences at Baylor College of Medicine. He serves as vice chair and head of psychology and co-directs the Obsessive Compulsive and Related Disorders program at Baylor. Dr. Storch specializes in the nature and treatment of childhood and adult obsessive compulsive disorder, anxiety disorders, PTSD, and anxiety among youth with autism. In addition to over 1,000 published articles and chapters in 30 books, he has received multiple federal grants to investigate treatment efficacy, mechanisms of action, genetics, bioethics, innovative approaches to phenotyping, and how to enhance outcomes for those struggling with OCD and related conditions. Dr. Storch serves on the International OCD Foundation's Scientific and Clinical Advisory Board, and he received the McFarland Park Champion of Peace Award in 2016. So, welcome, Dr. Storch, to the program.
Well, thanks. Call me Eric. I'm super pleased too. My cat Kevin is hanging out right here, so he's one of the viewers. But very excited to learn more.
Well, hopefully we will see Kevin at some point. My cat Eve, we got on Christmas Eve. She joins me for almost all of my peer calls. At some point, she likes to get up here and take a look, see who's on. All right. First question: you have devoted your career to studying and treating OCD. The fact that you have published 30 books and over 1,000 articles and chapters is truly amazing. What first drew you to this work? Is there any particular aspect of OCD and OCD treatment that you focus on most?
So I guess first and foremost, I mean, any success we've had in science or anything, it's all team. Whether it's the people we're helping or mentors or colleagues or everyone, it all comes together. And so any outcome is really reflective of that, I think. Someone the other day asked me, how I got into OCD. The thing I think about with OCD is that people can really get it, even if you don't have it. I was like, well, I never had OCD, but I used to be socially anxious. So something like this would have freaked me out. But I knew I had to do it. So I kept doing and doing it. But the thing of it is that cycle holds whatever the presentation is for an anxiety-based disorder. You're afraid of something, you're triggered, you do a behavior to mitigate the fear, and then you sort of don't learn what happens. That perpetuates over time. But for me, a lot of it was right place, right time, right people, and right mentors. So when I was in New York training, eating pizza daily, which just for the record, I think you can do and still be okay. As long as it's a good pizza, like Houston pizza doesn't count. Exactly. So I went down to University of Florida and I met my now boss, who is my boss then, Wayne Goodman. And had a psychologist, Gary Gefkin, another psychiatrist, Tanya Murphy, who were just amazing mentors, and provided me space to really delve into this topic. At the same time, the people who are affected by OCD are honestly like the best. So I always joke with the kids I treat. One of my buddies did a study, Dan Geller, that showed that the average IQ of someone with OCD is like 106. So I'm always like, yeah, they're smarter, and then they're better looking, they're more fun at parties. I mean, all this stuff, right? But it was sort of this kind of magic confluence of things, like the right people guiding you, the right opportunity from a career
Mhm.
standpoint, and then a group of folks that you're working with who really not only are appreciative of that, but at the same time, you're witnessing them get better right before your eyes. And I think that together with the gap in the field were just driving forces. I mean, despite obviously looking like I'm in my, maybe early to mid 30s, the reality is I'm not. And so when I started this stuff, there literally weren't, treatment options for kids with OCD other than medications. But we knew that kids were getting better if we did behavioral therapy. And so this ability to make an impact on the world, I think, has really been a driving force, again, with all the right people sort of surrounding you, working together for the singular goal. So that's more or less how I got into it.
Is there any particular aspect of OCD or OCD
Yeah.
treatment that interests you the most?
So my areas it has really traditionally been cognitive behavioral therapy from an exposure-based standpoint. And so I love working with kids. I'm a child specialist. If you can work with kids, adults are a piece of cake. So the age thing is sort of, all ages. The EBT really. And then the other part I love about academia, because there's some not so good things, it's the ability to kind of be in a nerd candy shop. So like one example is, and this is in depression, but we just got this big grant from Wellcome Trust to look at generative AI as a way of assessing depressive symptoms with things like facial affect and automatically detecting that and vocalizations and of course asking people. But it's this notion that you can really investigate lots of different areas too. So, for example, I'm part of a team that does work in deep brain stimulation, although not the leader of that team. I do a lot of work with assessment, but really that CBT piece is at my heart.
I meant to say this before we jumped into the questions is that I told you this before. You're one of the nicest people on the planet, right? So when I go to the IOCDF conference annually and I observe everything that's going on, sometimes between sessions, like you see where the crowds are, right, where the people pack to, you're always surrounded by people. And you talk about people who suffer from OCD and how brilliant they can be and all of that. At the very bottom line, people want help. And so they're drawn to people who they can trust and believe can help them. And there's always people around you. You're always so receiving, giving. So I applaud you for that. And that I try to tell everybody, this group of professionals in this particular community, they're unlike really any other community. That's been my observation. And so I applaud you for that. So for someone watching who is new to this world, to OCD, let's say they just got diagnosed or whatever, or they haven't been diagnosed and they're like, oh, something's going on. How do you explain what OCD really is and what it is not in a way that sort of advances knowledge and reduces shame?
So as someone who works with kids, I always like to, bring it down to like a sixth grade level, for everyone and lower if little kids. But what I talk about is, this is a biologically based disorder of the brain. So there's circuits in the brain, kind of like a hardwire, computer hardwiring. And so for whatever reason, whether it's, just a genetic basis or experiences that you have or just the way you see the world, this kind of circuitry just starts going awry. And so what we want to do is create through ideally through a behavioral therapy, either alone or together with medications, new pathways to learning how the world works. I have a mentor who he taught me the phrase the acronym KISS, keep it simple, stupid, which I was like stupid's a little harsh, so let's go with silly. But I always kind of think of that acronym KISS when I'm explaining things, when treatment or some concept. And so the what I love about OCD, I think why I get it is just the parsimony of the model. So there's some trigger. Well, what maybe it was an immune mediated thing. Maybe it was you had some traumatic event, whatever it is. But that triggers interpreted a certain way. You do things accordingly because you're thinking this bad thing's going to happen. And then here's the big thing. Because of those rituals or avoidance or whatever, you forget or don't learn how the world operates. So I'm admiring your screen, your background. And so if someone was afraid of bridges, like I interviewed someone once who had this deathly fear of bridges, and they avoided going on them. And they never then crashed off a bridge. And so the problem was is that they probably weren't going to crash off a bridge or fall off. They just never knew that because they didn't do it. And so that's the part I'm really harping on. And so what we do in treatment is really re-engage with the world in a way where the person is able to go after their goals, where we learn how things work. That's it. So it's more of a sort of an approach mentality that we're getting at. And I think the absence of that approach mentality results in people really not being able to get the stuff they want to get. So my job as a therapist is to really partner with them, encourage them, and be right there with them in the thick of it as we start leaning in and seeing how things operate. So the basic way is yes, while it's disorder of the brain and sort of circuitry, and we have a whole bunch of determinants for why person A versus person B versus C get there. At the end of the day, what we're really doing is saying, hey, we're here. We got to start leaning in and then seeing how things operate. And I think that part just again hits that KISS acronym, keeps it simple, but also gives us a framework for how we move forward.
Yeah, yeah, the whole simple thing, I tell people all the time, the formula for recovery isn't complicated,
Yeah.
and so we don't make it complicated, right? Keep it a simple task can be difficult to perform. If you complicate it, it becomes a billion times more difficult, right? So
Right.
let's keep it simple. Do we does current research I know when I was diagnosed back in 1997, my doctor told me the medical community doesn't know what causes OCD. And this was really on the topic of cure because I had read that it can't be cured. And he's like, they don't even know what causes it, much less whether it could be cured. So let's
Mhm.
focus on something else. What we do know, all right, people can improve. They can get to a place where they live virtually symptom free. It's possible to get better. But over the years, so since 1997, when I was diagnosed, I don't know that I've ever seen a conclusive conclusion about what causes OCD. Is there one? Has your research indicated that?
I think there are a whole bunch of factors that come in. I don't think we're at a point where we know what causes it. And frankly, it's going to be something multi-determined. Like we know there's a genetic basis, but it's not perfect. I mean, if you have an identical twin, you have OCD, identical twin who shares 99% and more DNA, has about a 40% chance of it. But that's a factor. That's important. Different life experiences can also sort of stick with people who maybe are more have a greater predisposition. That's a smaller group. Or in kids, there's a small cohort that have an immune mediated onset of OCD symptoms. And again, that's a theory of etiology. It's still OCD. It's just the point that lots of these things will sort of come about differently. I think what we're going to see, this is my prediction the next 10 years or so, is that we're able to start calculating things like polygenic risk scores that suggest who may be at greater risk for developing OCD, although they won't be perfect. But they may give us a concept of, what, if you have a kid and you have OCD, here's sort of the chance that they may have this problem or a different problem. One of the challenges with the genetic work, and we've been doing a fair bit in that space, is that when your DNA was created, gazillion years ago, it didn't confer with the DSM. So like we have these diagnostic systems that, it's like your DNA doesn't know. And sometimes I also think like we call things something and it actually may not be. So for example, there was a time where we called hoarding OCD. And then we're like, nah, that doesn't feel right. And it got broken out. But for a while, back when you're talking about like the 90s, when you're diagnosed, I mean, if you had hoarding, you would be diagnosed with OCD. And so I wonder what will happen there. Like, do we say that people with pure disgust-based OCD, is that really OCD or is that sort of a parallel or, or a spectrum condition? I don't really know. But I hope that within my lifetime, we start getting much better at understanding the underlying pathology and then letting that link up to diagnosis. But again, we'll see. The positive, and then I'll shut up, I promise, is so when you mentioned being diagnosed, I was a couple years from starting grad school, and my internship, so right, it was 2002, and so it began that 5 year sort of gap. But around that ballpark, we really had very few available options. I mean, you had a bunch of medications that showed good efficacy. Nifo and her excellent colleagues were showing, that in adults, exposure therapy was helpful. We had a couple case series of kids, and so where it's come now is actually that we know exactly what works. We know the sequencing of what works. And the big challenges are things like how do we get it out to everyone? How do we make sure there's high fidelity treatment? So there has been a lot of progress since that time point, just still more to come, particularly in the etiological space.
A related question, and I think you've answered it, but this is kind of a follow-on to just corral the parents of children with OCD. I get this question a lot. It really is from young parents and older parents who have a child with OCD, and they're like, they're searching desperately to find out if it was something that they did that caused their child to now suffer from OCD. What do you get that kind of a question, and what do you say,
Yeah,
parents?
I get that a lot. And I'm like, no way, not at all. The way I'll respond after saying that is, I reflect back when I had my kids and we went to these parenting classes. So I have my wife who's prego, and remember there's these 6 2-hour classes once a week, and I hate them because the classes were. Sorry if anyone teaches that. My apologies, but they weren't that helpful. Well, I was like, okay, as you're in labor, say things like "good job," and I'm pretty sarcastic too, and so I'm, well, raising my hand. Well, should I say something like "hurry up and push it out"? Like, come on, like, no, that. So those aren't things you should say, just in case you're wondering. But what I think they should do in those classes is say, "All right, Eric, if you end up having a kid who's not talking at a certain age, here's what you might be thinking about, then what you might do. All right, if you have a kid who's really struggling with these types of symptoms, here's what you might then do. And it can be talk to your pediatrician. My kid is being really, really irritable. My kid is, showing a lot of different things. And so as parents, what we're doing is we're being parents. And so our kid needs support, and we go and support them. Like that's 100% natural. And all you're trying to do is scaffold them to survive. So all you've done is love them. And so what we're going to do though in treatment is maybe take a different approach where we start parenting for confidence, versus parenting for comfort. But it's not at all about causing, because that certainly isn't the case. And it doesn't help, even if a parent was really accommodating. Like you're just trying the best you can. So that's sort of the way I take it. The same time, Shannon, and this one's a little bit weird to me in the field. When I work with a kid, it's a family-based treatment. So there are times when you'll have an adolescent and you just work with the adolescent alone because they're like, I want to keep this one-on-one. Cool, get it. Or symptoms are such, sexual symptoms like, yeah, you don't want to talk about it with your mom there. I get that one too. But by and large, what we're doing is having this approach to treatment where we embed everyone in it. Kid's the captain of our team, the parents are the cheerleaders, and the therapist is a coach, but you're trying to bring everyone together in order to move the system forward in a way that's just kind of matter of fact. And so I think that both gets better outcomes from a clinical standpoint because we're really having families engage in more treatment just without the therapist present, but it's also an acceptability standpoint. Like, when I go, take my kid to the doctor. My reflection on the visit with the doctor is usually, well, did they know their stuff? And did I feel comfortable with them? Did I feel connected to them? And based on those things, that's how I'm rating my satisfaction. And so here, simply put, I want parents to be able to reach out if there's a challenge and give us a call. And so that part I think is really helpful having that family-based approach. And it also allows us to normalize this stuff, get rid of any stigma or shame parents may feel, because they 100% should not feel anything in that space. And really say, hey, this is all of us together against this thing.
I think that's critical. tell all of the parents that I associate with that the best thing that you can do out of love is learn about this disorder,
Right.
talk to the therapist, find out what is helpful, what is not helpful, because you're right. Parents hate to see their children suffer and they'll
Yeah.
do anything to relieve that suffering. And it often can be not the right thing to do to help your child. And so learning education, and which is one of the reasons why I do this. This program, by the way, is intended for not only people who suffer, but family members, loved ones, and also new therapists. I want new therapists to go through this list of icons, hear what they have to say, right? Pick up something. So,
Yeah.
off my soapbox, OCD can look very different from person to person, even though OCD presents this basic model of obsession, anxiety, compulsion, right? The basic model. What are some misunderstood or less visible presentations of OCD where people are confused about is this OCD or not OCD?
Yeah, sure. So I think the unwanted sexual and aggressive symptoms are often misunderstood, and in a lot of ways, and it's a variety of things. Like, do they want to do this? Are they a danger to someone? Were they traumatized, and that's why this happened? All this stuff. The answer is, generally no. In fact, I always sort of joke like I'm more worried about the person without OCD than a person who's definitely afraid that they could do something that they don't want to do. And the data really speak to all that. But I think the misconceptions still prevail. It's important to be direct about this stuff. If a person's saying, and their history matches with this, I don't like these thoughts and I don't want to do them, great. I mean, there's not much more you need to do to sort of dig into that. I think the other thing that comes up, this one I hear actually a lot about it's not so much a symptom profile, but yeah, so there's sort of this concept of exposure therapy is hard. And so I hear that and I actually have a reaction to this, which is like, it's a hell of a lot harder to have OCD than it is to
Right.
learn a way of approaching something where you see, is this really a valid fear or not? So we know the outcome of OCD, which is it's just going to take up massive swaths of your life. On the other hand, there's an approach where you can sort of, you know, push back and you see what happens. And so I remember seeing this in a paper. It was consistently, it was like 25% of people drop out. And I was like, boy, we've never seen anything close to that. So I did a meta-analysis with one of my brilliant colleagues at Charlie Janko, and we found it was 10%. And this was in kids. And adults found something about the same, maybe a couple percentage points higher.
Mm.
And it was like, boy, that's actually quite low. And they were all lower than things like pharmacotherapy, pill placebo, relaxation, like controls, stuff like that. And so that was sort of another fallacy or like, fake news type thing. And then there's this other one that came up too that I thought was interesting, which is like, uh, these negative consequences. Something bad happens, someone does an exposure. So we did this other study. I like doing these studies that like push back on things people say if they aren't tracking with what I've seen and what I believe. And to me, it's all data. Like it's 100% all data. I have a hypothesis. It may prove to be, but it also may not. Which is, I could tell you about a study we're doing outside of OCD where I don't think it's going to work. But all science, right? So we asked a couple hundred therapists, like, "Hey, has anything bad happened when you've got exposure?" And it's basically the answer was no. So we said, "Okay, how many exposures have you done?" I'm simplifying this, in your career, a gazillion. How many times has something bad happened? Three. And it was hysterical, Shannon. Like once it was someone got locked in the back of a trunk. And I don't know how the exposure worked, but all I'm thinking is, hey, if I got locked in the back of a trunk. I'd probably pull out my phone, watch a few YouTube clips. I'm into like pottery these days, so it's like watch some pottery stuff. No one would bug me. Like it might not be so bad, but no, but I mean, I think when you talk about some of these myths, I think those symptom domains are a couple. I've mentioned already that too often clinicians are just having the kid involved, not the whole family. That's important. Same thing actually with adults. I think it's important. And then I think a little bit on the lay of the land of treatment. And again, just to restate, my approach to interventional stuff is it's all just interpret the data objectively. You can have your opinions, but the data are the data. You wish to challenge that, then collect rigorous data. That's, I think, the standard that the field of mental health needs, and any of the interventions that are being employed.
All right, let's continue on with
Yeah.
exposure and response prevention treatment. And I'm now I will for the rest of the day think about what the fear was that the exposure to lock them in the trunk was. Like the fear of mafia.
I know.
I'm not sure what it is, but the predominant clinical view is that ERP, exposure and response prevention, is the gold standard, and that's a quote, gold standard. Do you agree with that? And if so, why does it work?
Yeah. So yeah, I wholeheartedly agree with this. It's city field's interesting. It has a couple advantages relative to other things, like let's say the field of depression. So one is we use the exact same outcome measure, which is really a great thing. The Y box, and so like depression, we use the HAM-D or the MADRS or whatever. So it sometimes makes it difficult to compare studies, but that's the strength. Here's the other one. In exposure therapy, every single study that's out there has found the exact same effects, whether you're, in the US, Canada, Europe, excuse me, Australia. Um, and that's amazing. It's really amazing because what you're seeing is there's no allegiance. It's really this idea of, okay, let's test it. Let's see what happens. And then everyone's finding essentially the same things. Meds, you actually see pretty strong consistency too, overall. And if anything, maybe it's been a little bit diminishing, which I think is because it's harder to find people who are treatment naive over time. And again, this is more that comment is more reflecting the state of the literature on childhood OCD, where the original outcomes I think were a little more positive, but they're still very effective too. I think I think it absolutely is the first line treatment for OCD. They're promising interventions where there's some data being collected. ACT was front and center for a while. Unfortunately, I've only been two really well done OCD studies on ACT within the U.S. and there's several in Iran that were done, but there were some data points that were sort of missing that make it hard to be too conclusive on that. And the studies were relatively small, and so my framework on ACT is that it's a wonderful way of helping people engage with their symptoms and engage with exposure in particular. And then there's newer data in adults with OCD on inference-based CBT. There was a great study that came out of the Netherlands recently that compared almost 100 people to another 100 people, give or take a couple, with either ERP and inference-based ERP, and they did something called the non-inferiority study. What that means is that you're not saying is there a significant difference between A and B. You're really focused on the magnitude of the difference between, in this case, exposure and inference-based CBT. And so what happened was, and the basis of that is essentially a statistical determination for what a person with OCD would notice as being different. And so what that study showed is that the magnitude of the difference between these two treatments was sufficiently different such that a person would notice if they received exposure therapy relative to inference-based CBT, with exposure therapy doing 2 points better on the Y box across every time point, more or less. And so the good thing is, while that sort of shows us that these treatments aren't exactly the same, but it also says there's another tool that someone could employ as a potential intervention. But with the idea that exposure and response prevention is the first line intervention that we have from a psychotherapeutic standpoint. Now you asked the question of why it works. So here's the way I think about exposure therapy, and frankly, I wish we had a better name, like approach therapy, but that name sort of stinks. And so I'll work on that one. But it's really this sort of it's about engendering your curiosity in life and engaging with behaviors that align your values and your behavior in essence. So let me tell you what I mean by that. So we talked already about that whole cycle. So OCD, triggers this fear in your mind. And the fear could be, I have to do something a certain way or else it doesn't feel right. It could be disgust based too. It still works for all these. And the whole pattern, the whole sort of trigger brings about this pattern of behavior that keeps you from learning how the world works. So all we're doing with people is we're saying, hey, these things are important to you. These are things you want to get to in your life. And we want to align your behavior in a way by doing the things you can't do because of your OCD in a gradual, systematic manner where we learn what happens. That's it. And so I think the piece that really drives efficacy is that learning, that a person, for example, I saw this week, was afraid that they would drive off the road and kill themselves. Okay, I mean, it's possible. It doesn't seem likely, but let's see what happens if we do it. And then why is it important for us to do? Well, I need to get to work. I need to see my family. I want to go see my friends. And so you're aligning the the values at place together with with these sort of tests, these approach things called exposure. I think that learning is what really drives it forward.
You alluded to this a little bit before, and it's something that I really focus on when I'm coaching people through doing the really difficult, scary work of not giving into a compulsion, for example, and with all of this doom and gloom looming over them. So, one part of this question is when people are so afraid of ERP because they know they're going to put themselves into this situation deliberately. So, even before they begin, but even, as you're just going through treatment, and this applies whether you're deliberately putting yourself into this scary place or you're just living your life and OCD is now just hammering you with whatever you're doing. So you're exposed, whether you do it deliberately or whether you're not. So the real question is, what do you say to people to get them to do this really scary work? You alluded
Yeah.
to it earlier, like the comparative thinking, which is where I go. But just what do you tell them in that
Mhm.
moment about the choice?
Yeah. Yeah. When we start off with education about treatment, it's really all about what are the things you can't do because of OCD, but you want to do or you need to do. So it's all very much values aligned and goals aligned. And so that's sort of the major framework that we're bringing to the table. And I think the way I start is we talk about what's going to happen if we don't do this. As I mentioned, some of the efficacy data, and again, that works great for therapy, great for meds. The interesting thing as well is that placebo response in OCD is like zero. So if you compare that to depression, about 35% of people who are depressed, if we gave them a placebo pill, they'd improve. And in OCD, it's like 4 or 5%. That's, I think, a massive, massive thing at play. And we'll describe the why to that. It's because you keep feeding into it. You keep reinforcing this sort of, knowledge base that's not accurate. And so what we need to do is just be inquisitive, be curious, lean into it and start with low things and then let's see what happens. If my theory is right, great, give me a point and then let's move forward a little bit more and see. Because alternative is that what you're afraid of happening, i.e. your life being ruined by whatever, a sickness, going to jail, whatever it is. We know that's going to happen if we don't change your OCD. I think the other piece is just try and normalize it. Solid 24 in my mind, but in reality, I'm a lot older than that. And so the benefit of that is I'm seeing thousands of people with OCD in my clinic. And so we know that people can get better. We also know that it takes some work, but I will tell you, it takes so much more work to have OCD. The other day, I'm sitting with someone and they're like, "Oh, sorry." And I was like, wait, wait, wait. And I have sort of a self-deprecating, sarcastic, like joking approach and treatment. Like it's just too heavy. So we got to lighten it up some. And I'm like, all right. So I want to be clear. Your Y box said that you're spending 3 hours a day on OCD symptoms. So I just want to do a little napkin math here, buddy. So we're basically saying a day a week is just a race to stuff that is unnecessary. That's my words, not yours. But all right. So you're losing 52 days a year on stuff that you don't even need to do. Like
Uh,
52 days. I mean, that's a 2 month vacation in Italy where you can work on my future retirement goal, which is to become morbidly obese by eating Italian food. Like you could do that, but instead it's stuff that doesn't matter. Boy, I'm telling you a strategy that we can get 52 days back to do the stuff you want to do. And so I really just hammer home, this is all about you. It's all about your choices. But here's the benefit of trying to push back on it. And then I'm with them on this 100% of the way. Exposures we're doing together, I'm a cheerleader. I think those things matter as we go forward. Yeah.
I mean, that helps too because having the support helps somebody. Like in anything difficult in life, if you got somebody there to walk with you down this difficult lane. But there is really something to understanding that, yes, there will be anxiety when you do this. It will be there, right? That you're going to have immediate pain if you're not giving into a compulsion, or the way I say it, if you are depriving OCD of what it wants from you, it comes with some pain. But that immediate pain is productive pain.
Yeah.
You could choose to give in and go for immediate relief, but that means you're just going to be in this pain forever, right? That's what's
Yeah.
going to happen. And
Well
just
said.
trying to get someone to see that. The a follow on to that, what do you say to people who just they'll say, okay, well, I tried therapy. This is a very common non-specific statement that people make. I've tried therapy and it didn't work. What are the most common barriers to progress? And what do you tell people to get them back on the path?
Yeah. Yeah. So I'll share a secret right now. You can't tell my wife this, but I dated someone before her, maybe a few someones, but I've only married one person. And so I'll talk about that. You know, and if it's a kid, you wordsmith it differently, but it was basically like, look, it just takes one time to get it right. And so the other times it could have been just not the right person, you know, therapist. It could have been something that you weren't ready, but it just takes one time to get it right. And there's no reason why this can't be that time. You're here, like we work well together, you know, blah blah blah. But I really try to hammer that part home. I think some of the barriers are, you know, on the individual side is, you know, like they're not in it to win it. That's probably, I think, the biggest one. You know, you really have to sort of be in any intervention in order for it to work. Now, here's the thing of it. That is for everything. So I've been a soccer goalkeeper for 38 years. Yeah, I played in college, you know, still play. I think I'm doing at least above average in my over 50 league. If I told you I've broken my hands 18 times now, and so if you look at my fingers, they're all sort of like this, just jagged. Now, whenever you get these little mallet fractures, they give you this splint. And so what happens when I get it is that I wear it for a couple days and then I get annoyed because I can't type. I take it off. So the minute you get one of those fractures and you take off your little splint, it just breaks again. And eventually it heals that way. So there's actually nothing wrong with the treatment. It was all wrong with my engagement with the treatment. And so I really emphasize that part is that treatment can be fine, but if someone's, you know, not willing to sort of be in it, like that's their choice, but it's not going to work well. Same with the medicine. You can take Prozac, you know, 75% of the time when you're supposed to. It's just not going to work the same. And so I think that's a big piece to it. Of course, there's other clinical factors that can get in the way or that can have impact someone's ability to be engaged in treatment. And those are really reasonable issues that we have to think about and figure out how to resolve. I think on the therapist side, you have therapists that aren't ambitious. That's the term I'd use. So, you know, they're engaging in treatment that doesn't actually engage the problem. And I think this is something that I when I do these trainings, there is a risk for. So like I like telling the story. It kills me in a funny way, but I got a end of pandemic when things were sort of like opening up. They had a Father's Day gift of a massage, and I love massages. And so I go in there, you know, happy as can be, and the masseuse puts on their playlist, and so the first song comes up is Phil Collins, and I'm thinking like all right, like it's you know it's a decent song, and but you know it's not really massage music, but all right, who cares? Like you know, it's like rub my feet. And so the next song comes on, and it's Phil Collins again, and so now I'm just curious, like who's like what's happening here? Who has that? And third song, Phil Collins. And so I'm like loving it because I mean, it's just, it kills me. Like someone has a Phil Collins playlist. Like, how old are they? Really? And then they take a break middle to take a phone call. And so ordinarily I think I'd be fired up, but I'm like giddy because I already know the story that I'm like making of it that I'm gonna bring into teaching and all this. And so here's the thing to it. It's I got a massage, I got a unit of service, but the unit of service was diluted. You know, it had things that weren't helpful. It didn't focus on the right, you know, pain points or, you know, it was inefficient, whatever it is. And so I think those are factors as well that could come in on the therapist side, where they're not doing effective exposure therapy or they're not aligning it with people's values, which in that case is it is not exposure therapy. That's stupid therapy. So I think those are some therapist issues. And broadly, my belief in treatment is that not everyone actually, not every therapist should be an OCD therapist. And, you know, I think in psychotherapy training models, the fields made a mistake. And the mistake was, you know, yeah, let's teach people to be generalists. Well, we have a very specific intervention for OCD, which also is actually the exact same intervention for anxiety disorders that not everyone's really capable of doing. Not every therapist, to be clear, is capable of doing. And so I think that's this other sort of piece that I think a lot about, which is just because someone created this model doesn't mean it's the right model. Like I get OCD treatment, like it just makes sense to me what people are going through, but that you can't just talk it away. You and have to live it to understand it. But other therapists maybe aren't so willing or capable of doing that, and those people probably shouldn't be working in this space.
It's a great point, and you're not the first icon on this program who's talked about this. And it's good that your community is kind of self-policing because there are a lot of people out there who haven't really been specially trained in OCD, yet they're holding themselves out as, "Hey, I can deal with everything." That's a great message for therapists to say, "Hey, if you're gonna be in this space, learn how to be in this space."
Right.
And going back to your masseuse, that was clearly more about your masseuse, right? She's like, I like, or he or she, I like Phil Collins. I got to take this phone call. It was about
Yeah.
them, right? So it's good to self police the therapy community. What would you say to the patient? Hey, if what do you look for in a therapist? I mean, to see if this is sort of the right fit. Is that a
Yeah.
fair question?
I think so. I think it's exactly it. So, hey, how do you approach treating OCD? Tell me about your experience, doing that, things like that. And I think the other one is do you just feel comfortable with that? I think that's one of the biggest things, and in a way, kind of the art of this treatment is how do you build a relationship with someone where they know you care about them, and it's really all about saying, hey, you know what, we're going to work together for you to face something that's really scary to you, that's got in the way of your life, but we're going to do this together as a team. And so I think it's not just experience, but it's how they make you feel. Um, and that's why if it didn't work before, all right, sorry that didn't work before, but keep trying. It's a little bit like, yeah, you date a bunch of people, and at some point you say, all right, I'm going bald, I'm going to marry her. I didn't say that just for record. Someone could say that, but it's that idea of you just need that one time for it to be right. Again,
Right.
the therapist match before you sort of nail this.
And in fairness to the therapists out there, what you said about, and I'm speaking as a person who has OCD, who went through hell and made it out the other side because I wanted it.
Mhm.
Right? I looked at my life the way OCD had completely made me dysfunctional or non-functioning, but that's a better word. I wanted it bad enough. And what I tell all the people who suffer, you can't just go in and have a therapist wave a magic wand over your head. It could be, the best therapist in the whole world. It's not about waiting. You have to want it. You got to be in it to win it. Your words. And I, on this side of the railroad tracks, I tell people, if you do these things, you're going to get better. But you have to do these things, right? You have to do it. So that's another soapbox. Let's go over to families real quick. What are the most common ways families unintentionally accommodate OCD, and what could they do to improve? Just a
Yeah.
few basic pieces of advice.
Yeah, sure. I mean, I think like reassurance and receiving confessions are probably the most common. Taking demands off is another common one. I think it's it's shifting, and this happens 100% of the time in families. So if you're doing this to your kiddo with OCD, you're like every other parent. Don't worry about it. Just understand it. Work on changing it. I really think about this in terms of teaching parents to parent for confidence as opposed to comfort. One of the things I'm really grateful to my parents overall for teaching me about the importance of helping others. But we also grew up on a farm. My dad is a now retired cardiologist, where if you anyone who's a doctor's kid, like you're just not sick. My last time I was sick was actually, I think, around the time you got OCD, and I think I've been sick. I won't call it that because you just like suck it up. And and then my mom was this Kentucky girl, and I mean just salt of the earth. Like, taught us about education. I mean, all this amazing stuff. They're great parents. It was funny. If there was something that we really wanted or needed or were worried about, yeah, they would be empathetic, but it was like, yeah, you have to figure this one out, buddy. So I remember I idolized my big brother, and I always want to wear his clothes, even though they're like 8 sizes too big. And my mom's like, I'm not washing your brother's clothes every day after he wears them. You want them, you can do it. So here's 9-year-old me learning how to do the laundry so that I could wear his clothes the next day. And I think there's something to be said for that idea of, all right, well, we need parents to help support kids to learn how things work. And while it's difficult to see them distressed, this is how they're going to develop skills and understand what's happening.
To that end, how can a parent balance empathy with healthy firmness? Like, what's
Yeah.
that line?
Yeah. And some parents are do this easier than other parents. And that's, I mean, that's parenthood, right? So I think it's, it's just sort of be, put the choice in their hands, be supportive, express confidence in their ability, clear out roadblocks, explain why you're thinking. I know this is hard for you, and that you want me to do this. I'm not going to do this because I'm worried that if I do it, here's what will happen, blah, blah, blah. But know that you're able to get this done. And I'm willing to sit here and wait for you, for example, or afterwards have an ice cream celebration or, some sort of reward after. But I think the idea is to express confidence, clear barriers, and then be supportive. Like, I know you can do this. And so I think that's the piece to it. The alternative, when one accommodates, it just perpetuates. And parents will always accommodate. I mean, that's what we do. We could go, my 10-year-old woke up in the middle of the night and we're like, yeah, come in our bed. But that happens once, you know, every few years, I guess, at this point. So I think, that's the framework that we want parents to express confidence, express your belief in their ability, and then reward the effort.
It's a Pavlovian type
Yeah.
response, right? So, and then finally, for loved ones, well, not just parents, but loved ones who feel resentful, burned out, it's exhausting. I know you've talked to. What do you tell them? What's the coach Eric say to them?
Yeah, find a good bottle of wine. Here's what I say. There's a great study that came out of Scandinavia that showed that if you your kid went to get CBT, 72% got better. And these were actually clinicians that were just taught how to do CBT. And they weren't OC specialists, they got consultation, but 72% got better. You take the 28% that didn't, and half of them got sertraline, half got 10 more CBT sessions. About 50% of each got better. It's amazing. And here's the part I love, and this is what I tell them, Shannon. So they followed those kids 3 years later, and 91% of those kids were crushing it 3 years afterwards. So what that tells me is that if you engage in these things, you make this a focus of life, and I'll tell the kid this too, your odds of getting dramatically better are fantastic, fantastic. And so all this takes is you locking in on the process and the outcome in order to get the goal you want.
Okay, in the interest of time, let me jump to one or two questions designed for new therapists. Then you can answer both of these. I'm just going to ask them both, and you can just weave them into an answer. What do new therapists most often underestimate about OCD or OCD treatment? And then, what are the common mistakes well-meaning therapists or new therapists make in treating OCD?
Yeah. Yeah. So I think the first is, so I think new therapists, when you're coming out, very often they're taught in a model that says that they're generalists. That model stinks. You just can't be good at everything. And that's okay. I don't, go to my plumber for electrical. They're a specialist and vice versa. And so that's, I think, the model that we really need to shift dramatically. And so what I tell new therapists is find something you love, a group of people with whom you love to work, and then get really, really good at it. Go to more trainings and then go to more after that. Then get involved in the community. And if I see on your website that you do this list of things, I'm not sending anyone to you. Like, I can probably do okay at depression, but I'm not a depression specialist. It's not my thing. And so, I think that's a big thing for therapists is find something to be really good at.
Yeah.
And then dive in. I think mistakes that people make is they're inefficient. So I brought up the Phil Collins massage story because it really illustrated an inefficiency. I got a service, but the service was diluted by bad music and sort of inefficiency with time. And so that's something that a lot of therapists sort of screw up on is really, look, you're a specialist. This is where you're going. Now, that doesn't suggest that bad things don't happen. Your partner breaks up with you, you lost your job, whatever awful thing. Uh, but you know what? In that case, just like in medicine, I'm going to pull in a specialist for grief, for, divorce or whatever. And we're going to communicate as well. But you have, complicated problems. I can't address all these problems. There's not enough time. And so as I do that, I end up diluting actually the reason why you came in. And so I think that's a common mistake that therapists make as well is sort of, it's like the Beatles song Along the Windy Road. They approach treatment that way. It's like, oh, that's the shiny thing. I'm gonna move there. Oh, here's Kevin. I know, buddy. Come on. Yeah. He has a very difficult life overall. But but I think those are a couple sort of, again, mistakes that people make. I think the other misconception, what I love about OCD treatment is you see the improvement before your eyes. Someone is afraid of they could do something. The person the other day who's afraid of sort of hit and run OCD. All right, well, let's see what happens if we go driving. Let's see if you hit anyone. They didn't. They didn't check. Amazing. All right, what do we learn from this? Well, that I might not hit anyone. Absolutely. That's a big data point. I want you to drive again every day this week and see if you hit people. And so that's something that I think is amazing, like the dynamic nature of treatment where improvement is seen before your eyes. So those are a few thoughts.
Okay, I have one question from one of our viewers. This comes from Stacy. My mom will not stop giving me reassurance. How do I get her to stop?
I know. My wife, Stacy, says something to our kids, which I'm like, honey, it's a little creepy. Stop saying that. She's like, "You were under my heart for 9 months. I know everything you're thinking." Just cut that out. So I think moms are moms. One of the first, I guess there are a few thoughts about what you might do and I presume you've already told her, hey, don't do A, B, and C. Sort of an obvious and probably, dumb one, which you've tried too, I'm guessing, is to not engage her, in any conversation about OCD or related to that topic. It's a little bit like when people refuse to talk politics in families that have divided, political beliefs sort of along that pathway. I think that's one way, that you could consider. I think another way is sort of, you know, appreciating your mom's expertise for what it is. So a lot of times with reassurance, what people will do is they'll seek it from anyone, even if that person doesn't have really the qualifications in order to judge that. And so I think in your mind, you maybe even considering, hey, like, is my mom an expert in whatever public domain that I'm going to her for? And, not devaluing your mom, she's your mom. But this notion that her comment or her reassurance sort of is the end all be all. But I think, if you can limit your interactions to certain topic areas, that may be one way of trying to approach this, in addition to, educating her or seeing if there's some way of actually bringing in another family member or one of her great friends that she seems to listen to and understand, and becomes a different voice than your voice to say, Mom, stop doing this. But there's be a couple thoughts.
Okay, good. All right, one final question for
Yeah,
you.
man.
After decades in this field, what continues to give you hope about the future of OCD treatment? And what is one message of hope that you would give anyone who sees this video?
Yeah. I mean, the decades. I mean, man, it's like, I think it's just like 2.5 decades. But I guess it's three. It's three when it's 2.5.
Yeah.
Man, I feel old. Okay. What gives me hope? So past is the best predictor of future. So where we've come, in the last 25 years is amazing. And the next 25 years is going to crush it. Why do I think that? So cursed daylight savings, I will say, but in a typical morning, I wake up at about 5. Instead of going for a jog, or doing anything, I turn on the coffee machine and feed Kevin turkey, which I shouldn't because he's getting a little bit overweight, but he loves it, so he's in charge. And I sit at my computer and I start working on the next grant, the next paper. I start engaging colleagues around the world, in different scientific endeavors so that we can also get exposure therapy and other treatments to whomever, wherever you live. And so I'm not alone on this. There's a whole bunch of other people doing exactly the same thing. And so I think the hopeful piece is that there are a whole bunch of nerdy people who are only working this not for fame, not for fortune, but because this is their life's calling. And so that's how I think about this stuff. Like, we were raised, my family was raised with this idea of, you help a person, you save the world. And 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 I think that's the way we approach this is if you're there for someone, you say the right thing, or you just listen, it can have such an important impact. And so that's the reason why, I'm in this field and my colleagues are in this field is to try to sort of move things forward. And so having that idea that whether you see it or don't see it, there are all these people that are trying to push sort of push stuff, forward.
And to the person suffering,
Hmm.
um, right? That in and of itself, knowing that there's so many dedicated professionals who devoted their careers, their livelihood to helping other people in this space. That in and of itself is
Yeah.
a very powerful message of hope. But what would you say to the individual? Right?
Yeah.
Because yeah, you get what I'm saying is that somebody just sitting at home who's just suffering, saying that's all great. I'm really appreciative of everybody doing it, but what about me right now?
Yeah. The choice is in your hands. And so the choice of saying, do I reach out to a professional? Do I try to work on this on my own or family support? It's in your hands. We are at a point where we have excellent treatments behaviorally and pharmacologically. We even have treatments that involve surgery when none of those work that work amazingly well. And what's interesting about those treatments is that they're helping us inform the things like medications and therapies, too, as we discover things that you couldn't discover without, getting in someone's brain. And so, what I would say is that this is there's never been a more hopeful time for someone with OCD because of the information that we have out there, because of the access improvements out there, and the outcomes that we know associated with these interventions. I think the challenge, Shane, what you had hit on is sometimes it takes a minute to get it right. Meaning find the right therapist, the right time, a place that takes your insurance. But I think that's one of the hardest things for people that are struggling with OCD is to find access to treatment. And so sources like your work, or the International OCD Foundation, are huge. I have no life, so email me if there's something I can help with or point in the right direction. But I think that's probably the biggest challenge is accessing those resources, even those resources are out there.
That's a wonderful answer. And I'll make one comment. Compared when I was diagnosed in 1997, right, there wasn't a whole lot out
Yeah.
there. And I had two Navy doctors. I was in the Marine Corps when I was diagnosed. I had two Navy doctors. I'm not bashing Navy medicine. Mike Janicki, you and I both know Mike Janicki, God rest
Yeah.
his soul. But he told me one time, he goes, "You have no idea how fortunate you were that those two Navy doctors nailed your diagnosis." And from that point to where your profession is like eons apart. There's so much out there. So you being here today is just another example of how devoted the people in your profession are to helping people. Like you and Kevin took time out of your Sunday to come visit with us. I really appreciate you being here. You're just an awesome dude, a wonderful doctor, so pleasant to be around. And I just want to say thank you so much for everything that you do.
Nah, man. Hey, the pleasure is completely mine. And you know what? I'll throw the thanks right back at you because, being able to share information, and, you know, I mean, whether someone asking a question or us having this discussion, I mean, it is impactful. It addresses stigma, provides hope. I mean, those are the things we need because there are good treatments. There are pathways that are dealing with this very effectively. Hats
Yeah,
off.
thank you, sir. I appreciate it. And if you're going to be at the conference this year,
Oh,
I'll
yeah.
see you there.
I'd look
All
forward to it.
right. Have a wonderful weekend, and thanks again for joining us today.
Of course, man. All right. Take care. See ya.
All right. Yeah. All right. Bye
Bye.
bye.